to scientific session. The first talk is by Dr. Vinod Scaria, an alumnus of Government Medical College, Kozhikode. He is a clinician and computational biologist, current Chief Data Officer, Karkinos Healthcare, Adjunct Professor, IIT Kanpur, and his research focus is understanding vertebrate genomes, their organization, regulation, and how genomic variations impact them. He is the co-founder of Genomics for Understanding Rare Disease India Alliance Network, pioneered genetic epidemiology of COVID in India, and spearheaded initial state-level genomic surveillance. Author of over 200 research publications and 2 books. Elected Fellow of Royal Society of Biology 2017 and the Royal Society of Public Health 2022. And he will talk on the topic translating genetic research into clinical and community-based preventive strategies for childhood disabilities. Over to you, Dr. Vinod.
Thank you. Thank you, Professor Ashraf, for the introduction, and it's a pleasure to be in here. So, the next 20 odd minutes, I think I will briefly state something quite obnoxious. On some aspects of genetics and genomics, and some examples on how we could translate this information to a larger perspective at a community level. Now, before I start my talk, I always put up this slide, and there's been quite a practice for the last few years. I'm sure what you know what this is. What is this instrument? An MRI. Okay. What else? It's a CT scanner. Absolutely. Now, CT scanner is actually 50 years old, and if you really look at the perspective of humankind and how medicine has evolved, and I think this is the first landmark in the evolution of humankind of medicine. In the 50,000 years of humankind, just 50 years ago, that humans could actually peek into the human body without having to open it up. Now, I'm sure this has really transformed medicine in the ways of technology, because all the way medicine was practiced in the past was based on a patient who comes with something, and the patient is examined by the doctor. And for the first time, you can actually peek into the human body without having to open up the human body. And to me, the second landmark is our ability to sequence the genetic material in our genome, genetic material which drives a 37 trillion cell old machine. Now, how are these things being used? In fact, there are some problems that are really worth solving. And I'm sure you've heard in the early sessions how big these problems are. Now, when talking about children with genetic diseases, on an average, children with genetic diseases take 5 to 7 years, or in countries like India, even more, in some cases even decades, before they can even get to a diagnosis. A significant number of children actually die before they reach the 5th birthday, and in fact, 33% is estimated of critically ill infants in the NICU die before even getting a diagnosis. Now, why should we change this? Because we need to change this because a significant number of these children today can be treated with an effective medication or managed very well to be inclusive members in the society. Now, let's just take, for example, something that is very known, metabolic disorders of the newborn. They are quite very well treatable today. A significant number of them at least are at least the most prevalent of them are at least treatable today. They cause considerable numbers in mortality, but unrecognized, undiagnosed. They cause considerable morbidity, leading to intellectual disability or global developmental delay. And of course, there's a lost opportunity because it's treatable only if you can diagnose them very early on. Now, why doesn't diagnosis really happen? Because one, they're not suspected. Second, we don't have the tools to diagnose them very effectively. And third, there is considerable amount of investigations that happen which loses in time and space and of course money before they can even be diagnosed. Now, when we talk about genetic diagnosis, today we use multiple modalities of genetic diagnosis. I'm sure you would have heard about almost all of these. On one end of the spectrum, you have chromosomal karyotyping, or which looks at the chromosomal level abnormalities. Then you have techniques like FISH, chromosomal microarray, and so on and so forth. Then you have PCR based techniques, you have panel based sequencing, and you have on the other end capillary sequencing. Now, all of these are looking at genetic variations, but different resolutions of genetic variations. On one end, you are looking at millions of base pairs of chromosomal abnormalities. On the other extreme, you are looking at single base pair genetic variations. And of course, in between forms all the other kinds of genetic variations. Now, the real problem is here. You are using multiple tools, you are using multiple techniques. Each of them requires very different expertise, very different methods of doing, very different turnaround times, very different cost. And in, of course, almost all case patients, you do one or more of these. Now, that has changed at least in the last 2 decades, and that change has largely been what we call as a convergence in genetics. And the convergence in genetics is that you can actually cover all of this with one single test. And this one single test is what we call as a whole genome sequence. So, in other words, you can look at the entire resolution of genetic events fast, effective in one single test. Now, of course, in India, we are able to do this for the last 15 years. In 2009, India was the 7th country to be able to sequence its own human genome, and in fact, the first country in Southeast Asia to be able to sequence. Now, that sequencing has also allowed us to increase the spectrum of utility right from diagnosis to 4 more additional perspectives in our ability to classify a disease, in our ability to manage the disease much better in terms of pharmacogenomics, in our ability to prognosticate, because if you know the genetic variant, you can actually tell when is the severity going to happen, and more importantly, it allows for early diagnosis and intervention, and in some cases at least prevention by carrier screening or prenatal testing. So in one single way, it has transformed the medicine from just diagnosis alone to also 4 other things, which includes classifying, management, prognostication, prediction, and even prevention. Now, this is nothing new. In fact, if you really follow the guidelines in clinical medicine, whole genome sequencing is today the tier 1 test, not the last resort, tier 1 test for a variety of conditions, including the recent American Academy of Pediatrics recommendations in 2025, this year, a few months ago, recommends it's a tier 1 test for GDD, ID, and congenital abnormalities. And of course, there have been recommendations already for these indications from the American College of Medical Genetics, and of course today for the American Epilepsy Society puts it as a tier 1 test for unexplained epilepsy. Now, why is it a tier 1 test? Why the earlier tests were not effective or they were bad? No, the reality is that many of these patients actually lose considerable amount of time to get to a diagnosis, and that considerable amount of time is actually going to cost the window of opportunity for treatment, because a significant number of these disorders are currently treatable. In fact, if you look at global developmental delay, in a country like India, approximately 6 to 8% of children with global developmental delay have a treatable genetic disorder. That means if you could identify them in the early months, they could be perfectly normal members in the society. Unfortunately, they are not, because either we don't diagnose them or we use the right or the wrong tool to be able to diagnose them. The second is our ability to diagnose disease fast. And this is data from this year. This is from the Seattle Children's Hospital. And what they did was very simple. Sometime in May 2022, that is 3 years ago, they decided to stop all the standard of care genetic testing and transition to whole genome sequencing. Now, the standard of care genetic testing in 2022 in the US is pretty much the standard of care genetic testing today that we all use. By just making one decision to transform that to one single test, a whole genome sequencing, they published this paper which came in this year. From a mean time to diagnosis of 289 days, the time to diagnosis came down to 13 days. Now, if this does not really move you, I am not sure what would move you. And in fact, in India, we are even much better. We can actually do ultra rapid sequencing. That means you can sequence an individual and get back the report in 48 hours. Now, 48 hours is not time to sequence if you really follow this up. It is time from collection of the sample to delivery of the report, includes the logistics time. And we do this routinely in India for sick children in the NICUs. Now, having said that, what technology can do, the other important question that we need to ask is what is really prevalent? Are we acting on problems which are important, or are we acting on problems because somebody told that is important? Now, how do you really estimate prevalence of disease? In many ways, you estimate prevalence of disease by talking to doctors out there. So, of course, having studied pediatrics, if you go to Professor Ashraf, he would tell me these are the disorders which are prevalent. But in your posting, if you move to cardiology, you will find 10 other disorders which are prevalent. Now, just imagine if you, in a committee, you put in a cardiologist and a pediatrician, they're always going to fight with each other and never going to get a consensus. Now, how do we really arrive at a consensus? Because there is no way to normalize this, right? And in fact, if you are a good doctor in a particular specialty, you will end up seeing many more such patients. Like, for example, if you are in ICRA, which has a large kidney center, probably the largest kidney transplant center in this part of the country, you will see people with kidney disorders. Does that mean that kidney disorders are the most prevalent? Probably yes, probably no, but there is no way to adjust for that. And to me, the only way to look at prevalence is to be able to sequence normal people. Now, you might ask me, what does normal people have to do with patients with disease? Very simple. You can have a child with a genetic disease largely when two carriers marry with each other, right? And who are these carriers? Are people in this room, right? Who marry with each other, you have children, and if you have a genetic event, your spouse also has a genetic event, then you have, in a recessive condition, 1 in 4 chance of getting a child with a genetic disease which is recessive. Now, if I can understand what you carry in your genome, then I can pretty much predict, even without seeing a single patient, what is the really prevalent disease in that population. Now, this is population specific because marriage practices are also constrained by caste, creed, religion, and of course, social constructs. Now, if we can do that, you can actually go back to the clinician and tell that this is probably that it is missed by diagnosis and therefore can diagnose and can be treated. Now, I'm sure if the clinician is in here, you would completely agree to me is that you would not listen to somebody who comes and says that you're not diagnosing a patient properly or you're missing a patient and therefore the patient is dying. Now, to me, this is possible, and this is possible if you can even have a few thousand odd genomes from a population. I'll come to that in a few numbers. And if you can do that, you essentially need to provide only two things. One is a diagnostic. That means how can you diagnose that condition very effectively? Does not need a whole genome anymore, but you can make it very cost effective, and you need to create the evidence to be able to have clinicians diagnose such conditions. I will just probably give you a couple of examples. Now, until 2019, we are not able to do this just because genome sequencing was not available for the population. In 2019, with the Indigen program, which is India's first population scale program, where we sequenced 1,000 odd individuals from cosmopolitan populations around India. 1,000 in a million or a billion people is pretty much nothing, but we can still understand quite relevant problems which are pertinent to the country. Now, I'll put one example in here, and this example is from Calicut. And this is a genetic disorder called primary immunodeficiency. I am sure you will not have heard about this condition because these are not taught in medical colleges. Children with this condition do not have a patent immune system and they die to the disease. They die out of sepsis. Now, I studied in the medical college, so in chance meeting with Professor Geeta Govindaraj, I sort of mentioned that we do find a quite large carrier frequency of PIDs in the population. Is it that something that you see? And she said, no, I don't see these conditions. I work on HIV patients, which also are immunodeficiency but acquired, but I've never seen such patients before. So I sort of convinced over the next 3 years, trying to coax her to actually look for such patients. And what we found was even more remarkable, starting from a small program in 2018 to establishing with support with, of course, the government of Kerala, support from a grant from SCRB, and an association or a foundation called FPID, we set up a clinic set up diagnostic and started diagnosing patients. And today the single center is India's largest cohort for primary immunodeficiency disorder. Around 250 odd children diagnosed with primary immunodeficiency disorder, and this is treatable if you give IVIG, which is today given by the government of Kerala free of cost to all patients, and with hematopoietic stem cell transplant, or what we call as bone marrow transplant, which is also provided by government of Kerala with a one-time payment. Today there are children who can live with this disorder. And of course, many more families could now access genetic counseling services, because if you know the genetic mutation, then you can counsel them, and more importantly, you can screen for the newborn child. And the newborn child has 4 full months before the family can decide to either opt for a hematopoietic stem cell transplant or go into IVIG. And given the very high prevalence of the disorder, we are mad enough to actually pilot a newborn screening program. And as we speak today, the few hundred patients have actually gone to the first pilot newborn screening program for PIDs in the state. Now, does it really change lives? The answer is yes. And this patient was actually covered in the week. This was the first child to be born and screened and of course transplanted just because they got the genome in the right time, in the right place. And I think as we move on, many of them would actually become doctors and engineers and very productive members of the society. Now that comes to newborn screening, and of course the process of newborn screening is very well aware to all of you, and what is included in the newborn screening is also very well aware about you. Now the real question is, are we screening for the conditions which are really prevalent? Right? Who said these conditions are prevalent? And in fact, if you really go back, you will realize that some company made a kit, therefore everybody is using the kit. So we ask this very simple question. Let us take the newborn screening concepts in a very different way. Let us look at treatable causes of intellectual disability. Now there are around 80 disorders today which are treatable if you could identify them very early on. So we asked a very simple question: can we look at the prevalence estimates of carrier frequency in the population from the indigent data, and then look at each of these disorders in terms of prevalence estimates, because we can now understand and factor in the marriage practices across the population. And what we show is very stark. Approximately 1 in 11 Indians carry one variant for 37 or 36 odd treatable intellectual disability conditions. And what this would roughly translate is approximately 1% of children born into this country would have a treatable cause of intellectual disability. 1%. Now multiply by 25 odd million children who are born into this country, that's a huge number, which is today missed out because we are not able to diagnose them, because nobody understands that these diagnosis is possible today and these disorders are very prevalent today. Now if you look at the gene list and of course the conditions, I'm sure it will strike a chord here. The top candidate is Wilson's disease. I'm sure anybody who has passed through Medical College of Calicut would have seen not one, not dozens, probably a Wilson's disease patient every week, right? Wilson's is a treatable condition. Right? Very treatable condition with a very effective drug and a very cheap drug. It only costs what, 2,500 or 3,000 rupees per month to treat a Wilson's disease child. But do you find a Wilson's disease child which is treatable? Answer is no. Why do we don't find it? Because we don't screen for it. Why don't we screen for it? Because we are screening for something else. Right? Now assume that we could screen for Wilson's disease. Now all those children could have lived a perfectly normal life, in fact without hepatosplenomegaly, without intellectual disability. Now these are the top candidates that we have: Wilson's, PKU, biotinase deficiency, PKU with a point of caveat that is largely prevalent in the northern part of India. The southern part pretty much does not have PKU. I'm sure Kerala government had a PKU screening program, ran for a few months and realized quickly that PKU is not present in Kerala and therefore stopped the program. Now what we try to say is that there are many disorders which are 76 times more prevalent in Indian population, which are treatable today in the country, but for lack of a newborn screening program, we are not screening them, and therefore this child do have disability and even a painful death. So we started to change this disease by disease, and this is for Wilson's disease. In 6 months, we could create the globally largest cohort for Wilson's disease in the country. Today we have around 1,000 odd patients screened positive for Wilson's disease through this program that was set up by my colleague Dr. Binu Kumar. We actually created the globally largest databases for Wilson's genetic disease variants, and we also created a very cost-effective, affordable screening tool using next-generation sequencing, which can scale from 100 samples to 3,000 samples in a very cost-effective way for newborn screening programs in the country. We are actually talking to some governments to sort of pilot this out as a newborn screening program, just because this is a very treatable genetic condition. Now, of course, Wilson's disease is not amenable to biochemical screening, right? And in fact, most of the newborn screening programs are phenotypic or biochemical screening programs. And given the number of diseases which are today treatable, it is very unlikely that biochemical screening programs are scalable. In fact, even in the US, there are only around 37 odd conditions which are treatable today, which are screened today. So the real question is, can we really scale the way to screen these individuals? And this concept is quite some time old. And the idea is very simple. If these are genetic diseases to start with, we should be able to sequence these children to figure out what is prevalent, what is penetrant, what is have large evidence for actionability, and more importantly, what is treatable. And treatability also needs to be qualified by an accessible and, more importantly, affordable drug. Because you don't want to tell a parent that you have a genetic disease that will cost probably crore rupees to treat every year, and they're not going to afford. And probably most people in this country are not going to afford. So you need to have a list of individuals or diseases which can be treated using an accessible and, more importantly, affordable drug. And in fact, a lot of programs around the world have piloted doing this, and in fact, the early data for most of these programs have started coming in. And this is one of the largest of those programs, called the Guardian program, which was in Boston. Screened around 4,000 odd children, and what they show is that 3.7% of children born do have a genetic actionability on their whole genome sequence. 3.7%. And probably that is the number that we are currently missing because we don't have a newborn screening program. Now, of course, the treatable conditions in the United States might not be the treatable conditions in India. So we need to build consensus on what is really treatable in India. So early this year, we started this program called Genesis. And the idea was very simple. We will ask every pediatrician, cardiologist, nephrologist, so on and so forth, on what is really treatable in your clinic. If a patient comes to you, is it treatable? And the conditions are pretty much constant, which is called the Wilson and Juckner's criteria. Are there prevalent genetic conditions? Are there penetrant genetic events? Is there high evidence of actionability in terms of a guideline? Is it treatable with an affordable and accessible drug? And what we found is that there are around 453 genes linked to 469 disorders which are treatable in India today, right? And with a cumulative population frequency of approximately 2% of children born into this country. So if you today do a whole genome sequencing of every single child born into this country, 2% of them would have a treatable genetic condition which is treatable with an affordable, accessible drug. And increasingly, this list of drugs are coming up, and I'm not sure you have followed this news that the High Court in Delhi has allowed one of the Indian manufacturers for risdiplam to actually break the patent and manufacture this. And what this has really transformed is a 6 lakh rupees month treatment has become 12,500 rupees. Now, the question is not about whether SMA is treatable. It is treatable today because 12,500 is what every government in India can afford to have for a child with SMA. The question is, are we able to find every SMA child? The answer is no, right? Can you tell me what is the prevalence of SMA in the population? It's approximately 1 in 10,000 individuals, right? Now just imagine, what are we really missing out, right? Let's keep aside the cost. The cost will come down because courts will rule as long as manufacturers will manufacture. The cost has actually come down, 11,500. Every single child with SMA can today be treated. But are we able to find the SMA child? The answer is no, because we don't have a newborn screening program for SMA. Now, can we really wait for the biochemical newborn screening program for SMA to be added in the government program? Absolutely impossible. It will probably take a decade of time. Now, why I'm saying this is because there's even more something remarkable that's happening around the world, and this is the cost of sequencing. The first sequence was available in 2003. It costed $3 billion to sequence a human genome. And in last 20 years, it has undergone 1 million fold reduction. There's no technology in the last 2 decades that has crashed 1 million fold in the last 2 years, 20 years. And the line that you see there is the price for semiconductors, right? You have a technology which has even surpassed the price crash for semiconductors. And just imagine now if this continues for the next 10 years, right? Whole genome sequencing will reduce by 1 more million fold, right? That will make it accessible, affordable to practically everybody. And in fact, that would mean a lot of things. In fact, I'm not sure you have followed the news. In 2025, NHS plans to sequence every single child born into the country. Every single child. And I'm sure this will also happen in India. It's only a matter of time, and is also going to start the initiative. I think we should look forward to a genome generation where a genome sequence is the right of every child at birth and not really a privilege for only who can afford to have it. Thank you very much, and I can take questions.
Thank you, Dr. Vinod Scaria, for that excellent talk about the role of genetics in the diagnosis, in the management, as well as the prevention of the diseases. We will have the questions at the end of the session after the completion of all the 3 talks. Please be seated there, if you are comfortable. Okay, now I will.
Thank you very much. I have few questions I have reserved for the discussion time. So next we have Dr. Sumita Dandal. She's a professor and head of the Department of Clinical Genetics, CMC Vellore, and she has advanced training in clinical genetics from 2001 to 2004 at the Women's and Children's Hospital, Adelaide. And her area of interest is of dysmorphology, population genetics, community genetics, lysosomal storage disorders, alkaptonuria, neuromuscular disorders, and autoimmune disorders. So, welcome, madam. Over to you.
So, a very good morning to all of you, and I am delighted to be here and see this unique place. And on behalf of the organizers and especially Dr. Dilshat, I am just privileged to be here. And I'm in the next 20 minutes. I'm just going to take you through what clinical genetics role is there and what advances for the precision medicine. So, I'll just talk on the impact of the Human Genome Project on health. Why clinical genetics? The phenotype matters, some case scenarios for diagnosis and management, implications and risk predictions, and the way ahead. So, 3 decades from now that we had started the Human Genome Project, and we know that it started in 1990, but it finished early, and the whole human genome was sequenced by 2003. And 2013, the cost had reduced, and we had 1,000 genome project. And now in the current scenario, we have a 10,000 genome sequenced in India as well through the Genome India project. So we know that now understanding of the whole how the genome functions and unraveling the functional basis of human disease, it's still going on, although we have really sequenced the whole genome. So the major impacts have been on cancer genomics, the rare disease unraveling, pharmacogenomics, prenatal genomics, and precision medicine. So now we know, Dr. Scaria also told that human genome sequencing is now trivial because of the real hard work of the researchers and the health professionals. But clinically understanding a patient's genome sequence may not be trivial. So here the role of a clinical geneticist becomes paramount. So we all are familiar with the term VUS, and you can see how it can impact. So what is the interpretation? Because we know that it is going to have effect not only on the patient but even the friends, the relatives, and as a society as a whole. So we have the bench on one side and the bedside on the other. So clinical geneticists have the role in between, where they are actually translating the benchside work into the bedside, and we have to keep in mind all these factors such as confidentiality, privacy, medico legal aspect, social aspect, in short the ELSA. So the precision medicine basically has got its role in diagnosis. So risk assessment, risk modification, pharmacogenomics, the new biology and drug development, and as well as gene therapy. So first of all, let us see what are the challenges of diagnosing, because diagnosis in genetics is a challenge. So you have to have a full clinical history and examination. Of course, you can confirm by the investigations, the biochemical and the molecular, and then we have the management, which will be treatment, which is specific, and more important, it is the supportive treatment which is also going to matter to give a wholesome treatment. So we know of genetic variations. There can be polymorphisms where the frequency is more than 1% and it's unlikely to cause disease, but it can have effect on the modification or the presentation of the disease. Then there are these mutations which are less than 1%, and they can be single nucleotide polymorphism or insertions, deletions, which can be ranging from few base pair to a larger length. And you have copy number variation, which can range up to 1 kb of the DNA. So my previous speaker has already told you about the scale of the testing or the genome which is involved, and similarly you can design a genetic test. So of course whole genome is at the last, where we have starting from karyotype, the fish, the array techniques, the MLPA, and the various type of PCR based Sanger sequencing and clinical exome and whole exome. So this is just a diagram to show you the scale or the level of detection and the scalar defect which is occurring at the genomic level. So you have on one hand the karyotype, where you can diagnose with a chromosome copy number is either deleted, or it is an aneuploidy which has is a trisomy here, which you can see, or it can be through an array where you can see the the bits of the chromosome deleted or duplicated. And you have MLPA, which looks at exons of the gene, or you can look into a single exon where you see the sequence actually where it has changed to in a nucleotide level. So the genetic workflow depends on how you do a pre-test genetic counseling, which will depend on your clinical evaluation. So once you have the counseling done, you choose for a genetic test, and then you have a post-test genetic counseling parallelly along with other investigations and management. So this genetic test will give you a risk assessment and the prognosis, and also you can do a preclinical counseling of family member, follow up and therapy. So basically the phenotype is very important in managing any case. So the phenotype not only depends on the genetic variation, but it also has other things such as the epigenetics, the physiology, the lifestyle, and entire factors around you which can lead to a phenotype development, and therefore you have to look at those factors also to be more precise and accounting for the individual variability. So I'll just take few cases here where you have this case of all of you may have seen with the developmental delay. There is a coarseness of face, there is organomegaly, you can see the bulge here, you can see the Mongolian spot, the coarseness of the face, and some corneal clouding. So this was like a MPS 1 or mucopolysaccharidosis 1. You have supporting evidence with the radiographs where you can see this J-shaped sella, the bullet-shaped metacarpals, and all these radiological changes, the flared ilia, which are together called as dysostosis multiplex. So now you know sort of the diagnosis is narrowed down, and you can do a urine screening test by which test for mucopolysaccharides, and which is strongly positive, and you can know that there is an enzyme for it. You can order for that enzyme test and get the result. So in this you can confirm by a genetic test which can be a single targeted gene or a panel where you can cover all the mucopolysaccharidosis gene. This is another child who has more of less of developmental delay but more of joint problems in the form of stiffening, contractures, protruding abdomen, and hearing. He is using the hearing aids, and also has hepatosplenomegaly and with a systolic murmur. So again, if you see the coarseness of the face, but here for any genetic workup, a family history is very important. So you must have a 3-generation pedigree drawing, and once you have that, you will be able to find out what may be the inheritance pattern. So on probing the history, there is a history of one of the maternal uncles dying of a cardiac surgery, and who had some sort of similarity with the current proband, and therefore you can interpret that this is probably an X-linked disorder. So once there is an X-linked disorder, then you know that out of all the MPSs, one of them is X-linked, other are autosomal recessive. So that is Hunter syndrome or MPS 2. So this was then you can correlate it with the genetic testing where there was a missense mutation in IDS gene. So once you have this, you will note that there was a genetic test and there was a biochemical correlation, and diagnosis was possible. I have here I have just rubbed out the patient names too, because there is confidentiality and privacy which has to be taken into account. Now why do all this? Because we know that there is a specific treatment. So we have this another case which was, as you know, for diagnosis of genetic disease, it's like an odyssey for the parents, and they would have seen at least 5 to 7 doctors before they reach a final diagnosis. But now that time has reduced because of the programs and because of the molecular testing and intervention centers like you, that where you can detect early. So this was another quite a severe case of MPS 2 with severe involvement of developmental delay and corneal clouding, but unfortunately by the time we could diagnose, this child could not survive and was reported to have expired. So this child was actually found to have a copy number variation in exon 4 to 7 deletion, which we found out from our in-house IEM panel. So to put it in short, when you need first of all you must suspect that it could be a genetic problem which can be treatable. So take a careful history and examination, and family history is utmost important to know the inheritance pattern because it helps, and then molecular testing and reach a diagnosis to get a specific treatment. This is another case where you have joint problems, and we had thought it could be either an attenuated MPS 1 or Hurler-Sheet type, or MPS type 6 or MPS type 2, because there was some corneal clouding, and in MPS 2 you don't usually get corneal clouding. So we had to depend on the genetic test to see that the diagnosis was actually MPS 2, and there is, which is again an X-linked disorder. So here there was no family history. So sometimes family history may be helpful, sometimes it may not be. So but you have to take into consideration all the aspects, the clinical aspects, the biochemical aspects, the radiological imaging and the molecular test, and together make a diagnosis for the phenotype. So with this we could confirm that the mother was a carrier, and then it is possible to counsel the family for the future pregnancies and early detection. So I would like to also say that the genetic disorders have a highly variable phenotype. So this is also a case of born to non-consanguineous parents, a 4-year-old boy with developmental delay, seizures and hypoglycemia. And the third day there is he had aggressive behavior at 4 years of age, poor response to name call, fragmented sleep at night. Family history was non-contributory, but on a biochemical screening he had very high levels of urine and serum glycine level. Why we do this? Because it is treatable. So of course you have to confirm by genetic testing, but then after confirmation, the earlier the diagnosis, the earlier the treatment, the more is the response. So now, because of the advanced genetic technology, invasive testing are being avoided. Previously we did muscle biopsy for Duchenne muscular dystrophy. Now hardly anybody does, because you have complications of anesthesia for the children and there have been problems. So now we go in directly for genetic testing. Similarly, we have for liver biopsy, we used to have for glycogen storage disease, and even after the invasive testing, the actual type of glycogen storage disorder was not often clarified. So we have to depend now on molecular testing and avoid the invasive testing and get an early diagnosis. So the important thing is that which genetic test do we choose. So that depends on the clinical acumen and the supporting evidence, the biochemical as well as other test, imaging, MRI, which can be used. So you have to choose whether it's a karyotype. So you won't do a whole exome sequencing for Down syndrome, you will go in for a karyotype, or for Duchenne muscular dystrophy or SMA, you would do an MLPA, because that is the best method to pick up about the majority of cases, and then go in for more advanced techniques. Of course, if whole genome sequencing costs come down, then it may be possible to diagnose even these conditions early. So some rare disease unraveling and prenatal genomics is where we have made so much advances, and the clinical significance of the variant depends on a number of principles of genetics which apply at the clinical level. So family history and phenotype at the top, plus we have to look at other things like segregation of the variant, whether it's a dominant or a codominant or a recessive or an X-linked, whether there is random assortment, whether there is consanguinity, and whether it's a heterozygous or a loss of function or a gain of function. So we have to apply the principles of genetics to reach conclusions at time. So this was again a child who had got this frequent URIs and abdominal distension, weakness and lethargy, and was born to 4th degree consanguineous parents. There was nothing much otherwise except for some pallor and a organomegaly. So this was the child who had the consent has been taken from the parents that she looked normal without any dysmorphic features, but you can see the umbilical hernia and there was a poor growth. So with all the investigations and including the liver functions as well as ultrasound and ophthal examination, because there was a suspicion of a storage disorder, we started working up this case, and then finally there was a biochemical diagnosis of because of the sphingomyelinase enzyme deficiency, there was SMPD1 variant, and which pointed out to Niemann-Pick disease. So why this is possible, why it is important to diagnose? Because there is enzyme replacement available for these conditions, and there is, if there is a sort of available funding, then through the National Rare Disease Policy or some other funding, it is possible to get the enzyme. So this child has been getting from 2022, and she has got remarkable improvement with growth and or her organomegaly subsiding. So there are some rare diseases where molecular genetics has helped to diagnose. Dr. Scaria already told that Wilson's disease is a common problem. So this was a child with Wilson's disease, and there was some dysmorphism associated with it, and this child was not responding well to the standard care of Wilson's disease. On taking the family history, there was another sibling, a brother, who had intellectual disability with some seizures and autism like pictures. So because of these not tallying, we did a CNV or a chromosome array, and though it was confirmed Wilson's, and the molecular testing also showed that there was Wilson's disease on targeted ATP7B gene, which was a compound heterozygous. But still, when the array was done, this is the second child, you can see that there is a dysmorphism along with some absent of speech and autistic behavior. But and even the MRI images, which did not correspond to Wilson disease but rather showed heterotopia or cortical malformation. So we did an array, and we found that there is a deletion in the first child or the elder brother of chromosome 5. 5p. Now 5p is often associated with Cry-du-Chat, but this was a different region which was involved. So this was another brother who had this duplication of the same region. So sometimes you can actually unravel, and the mother, when we went back to the age old karyotype, we saw that the mother is having a translocation. So it may require multiple methods to actually diagnosed. So this was another case where prenatally the mother had come at 7 weeks with a child with developmental delay, and when we examined the child, we have to call in the other members. We saw that there is dysmorphism, and this was a child with Cohen syndrome. So we can take full history and then diagnose child, then go for proper genetic counseling. So although consanguinity can be there, but it doesn't mean autosomal recessive. So you can also have maternal mitochondrial gene involvement, which can cause problems. So these are some cases where I would like, but this is just the summary, that you have to have a family history, investigations which support the diagnosis, look at the phenotype, and then counsel pre-test as well as post-test. So these are just the summary of what tests can be done. So inherited cancers also, so I will not go into the details. So there have been some challenges in India because we have a diverse population, we have consanguinity, we have admixture of genetic pools, we lack trained geneticists, there is lack of awareness and stigma, high cost of diagnosis, there is lack of palliative care, and policies may not be adequate for holistic care. So thank you all for this opportunity, and
thank you, madam. We will have the questions at the end of the third talk. The third talk is by Dr. Vivekananda Bhatt. He is an assistant professor of medical genetics at Kasturba Medical College, Manipal. Specialized clinical geneticists focused on the diagnosis, workup, and management of rare disorders, providing comprehensive care to affected families. His expertise spans clinical practice, including prenatal diagnosis and advanced diagnostic laboratory work like next generation sequencing. Has several papers and publications to his credits. paid early career fellowship for applied research from Department of Science, Government of India. Actually, the first talk was on the importance of the genetics in the diagnosis as well as the management and prevention of the disease. Now, Dr. Vivek will talk on ethical and policy aspects in genetics testing for childhood disabilities, which is a very important because these testings are increasingly available in India now. So, ethical consideration as well as the policy making about the tests are very important. Over to you, Dr. Vivekananda.
Thank you, sir, for the kind introduction, and thank you, madam, for the invitation to speak. So today's morning sessions have been excellently placed. So sir explained how the crux of preventing disability is primary prevention, is that we catch them early. So one way to catch them early is to diagnose them early, and my previous two speakers have well elaborated how the same thing but different perspectives. Dr. Scaria's perspectives from the genotype side, how you can use genome sequencing as a tool to identify carriers or use genome sequencing as an early diagnosis tool. Madam emphasized how phenotyping is equally important. The more intelligent we are in phenotyping, the more likely are we to get a diagnosis. But whatever path you take, you have to test, and when you have to intervene, there are always some issues, and this is something that is increasingly being important to be kept in mind when talking to these families, because they have already a lot of challenges, and testing them and starting intervention brings more issues. Thank you. So what we can definitely agree is genetic testing has been increasingly used. Lot of reasons why this is happening. One is the increasing yield. Day by day we are seeing that the number of families we can diagnose is increasing. The technology is improving. The newer technologies are able to sequence faster, sequence better, have wider coverage, and easy accessibility. Most genome sequencing companies are just a call away. They will come to your clinic, make sure they take the sample, and they go back. Cheaper and cheaper. This is what sir showed again. This is the Moore's law that says how technology will help in reduction of cost, and genome sequencing cost have plummeted, as he rightly said. But the achieving a diagnosis allows for early diagnosis. Once you diagnose is when you can provide interventions, whatever are treatable, non-treatable. Crux of that is early diagnosis, aids in management, and prenatal testing. At least can you give another healthy child to the parent. The childhood disabilities are more specifically highlighted. I'm highlighting here because just if the 50% is the diagnosis, that means the other 50% will remain undiagnosed. So many of them will reach start towards the research side of testing, and with the research comes a lot of ethical issues. And because of the knowledge is improving, so we are understanding more newer phenotypes associated with known disorders, or new variants. The gene is already well studied, but the variant we have got is very new. or there are new genes that we are able to now pick, variants in new genes, and novel techniques and therapies. So all this, which is very unique to childhood disabilities, makes them participate in now some or the other form of research, and with research comes lot of ethical issues. Three tiers of ethical concerns. Genetic testing itself brings lot of ethical issues, which we will discuss, but you're doing these testing on children who are not able to take their own decisions. So there is a caretaker or there is a family member, parents, who will take decisions on their behalf. So that brings another layer of complexity. Plus you are talking with about disabilities, children with disabilities who are again not able to decide or do not know what is the implication of testing on them. So there are three tiers of ethical concerns, and with each tier it becomes more and more complex. So this is something that we all know. The four main pillars of ethics is autonomy, is that it is my life, I decide what happens with my life. Beneficence is doing good. Non-maleficence is at least primum non nocere. At least if you're not able to do good, it's okay, but please do no harm. And finally is justice. Are all individuals having equal opportunity to access certain point of care, which sir also pointed out. So ethics, the principle of ethics are, let us say there is a family who is has disability but is not coming to main concern, that is about justice. They are not able to access your care although you have it, but lot of ethical issues can happen because of the disorder itself. The disorder may be very difficult to diagnose. Not many disorders can give lot of information during phenotyping. Genetic testing has its own limitations, and the child himself can have complications. And here in India especially, it is a paternalistic society where people decide, the parents decide, or some member of the family will decide. So all this brings ethical issues not only with the child but also to the family as well. So let us take, I have some case scenarios so that we will understand the actual scenario. These are very common. That is why it is not one particular family that I have discussed here, but this is a very routine thing that happens in a genetics OPD. So parents of a 3-year-old male child have come with severe global delay and epilepsy in the child. We ask for exome sequencing. We find there is a novel VUS in this child. Now the gene is known, but the variant is novel. So most of the time this would get categorized as a variant of uncertain significance, and this by definition says it is not actionable. So but family is still interested to pursue because they want another child. Now if it is a VUS, guidelines say the prenatal testing is not to be done. Now parents that we have offered them some functional studies to validate the variant, but we know even if the variant is validated, this particular disorder may not be curable for the child who has the disability. But for that, for the next pregnancy, they have to confirm the variant for the pathogenicity of the variant. That means this child who has disability, who is not able to decide for himself, is now like a experimental person for the family, so that they can have another normal child. So this is not considered. How do you take this? Again, ethics is different from legality. You cannot be punished for being unethical. It's about moral codes. We say, I will do everything good. If you don't do good, if you kill somebody, you will go to jail. But if you are not doing this, nobody will jail you. So what is happening to the child whose autonomy is lost? Because now this child is a guinea pig for the family to have another child. Let us take another scenario. So we have a 40-year-old pregnant woman who is referred for high risk for trisomy 21 during her antenatal workup, and she undergoes confirmatory testing and finds out it is trisomy 21. Now we offer, again it is non-directive counseling. We say if the child has trisomy 21, 1, 2, 3, 4 are the issues, but it is upon you. If you plan to continue the pregnancy, then this will happen, this. If you discontinue this. So it's non-directive and absolutely upon the couple to decide, but this couple decides to continue pregnancy. All are actual scenarios. Now this child is born and now grows up to be an adult, let us say, and whatever you say, child will have some intellectual disability for sure. Child will have congenital heart disease, hypothyroidism, and in case the child is not able to come to the mainline society, child will remain isolated. And would the child blame the parents in future for allowing him to be born? I do not know, but this is something we should think about. Did the parents' decision to continue the pregnancy, is it about autonomy of the child versus autonomy of the parents? Okay. So that is why the first concept is autonomy, like who we decide what we want with our lives. But in certain scenarios like this, children or children with disabilities, when it is someone else who is giving consent, so it's proxy consent versus the child's assent. Who is deciding for whom? Respect the child right for an open future. So that is why, especially in DSDs, we do not do a complete genital alterating surgeries when they are in children unless it is really necessary, because once the child becomes 12 or 18, they decide they want to be reared as a male or a female. So but here parents are deciding. Avoid testing for adult onset conditions, they are actionable. So a lot of scenarios I have in the upcoming slide, which says if there is something that you cannot do today to change the course of the disease, don't test them today. Yeah. So another scenario, there is a severe child with severe delay. So he is suspected to have a mitochondrial disorder, and genetic testing is done. There is a VUS, heterozygous variant in SLC25A4, that causes this mitochondrial DNA syndrome, but it is a VUS. However, the benefit to risk ratio, the starting of the mitochondrial cocktail, even if the smallest doubt we have, we do start to see maybe it may work, let us see. But it is started, the story does not end here, and this is again something that has happened. The mother conceives again, and the prenatal testing is done, and the fetus is found to be heterozygous for the variant, and the obstetrician tells the family that this child also is affected, and they have an MTP. Now some years later, there is a publication that says this variant is benign actually. So did we murder the second child, the pregnancy? So again, these are ethical issues. There is nothing wrong and right, but when again the VUS is a menace today, because people are reporting left, right, center, and it is unavoidable because not everything about our genome we know. So that means VUS will stay for a very long time, and because VUS are not actionable, this was something that was done. Also, the variant segregates in the asymptomatic father. Now what do you say? Father is fine. So another case, 6-year-old male being evaluated for proximal muscle weakness. Pediatrician suspects DMD, and testing is done for DMD. DMD is confirmed. No, thanks. So DMD is confirmed. Now they have a 3-year-old younger brother who is asymptomatic, because symptoms in DMD usually start by 5-6 years of age, and now they are persisting. Now they are concerned, does my second child also have DMD? Now they pester the pediatrician so much that he says, oh, I will not do genetic testing, but let me do a CPK, and CPK is elevated. Now what is happening in the minds of these parents? Do they have the same feelings towards the child now? Now they know they are looking at a time bomb who is going to stop walking by 10 years and probably going to die by 15 years of age, which was not so if we had not done the CPK. So the perspectives of families change when they have the genetic diagnosis. So that is something that to be known. So primum non nocere, that is my this one, that first do no harm. Maybe we may not directly benefit the family, but definitely we must not create concerns to them. Avoid action that worsens child physical or emotional development. Prevent over medicalization, unnecessary tests or risky interventions. Cautious of unproven therapies. This is another stem cell therapy. So for each and everything, just do stem cell therapy, and again I have not given proven results. Avoid harm by causing stigma. Yeah, that is another thing. Now parents look at this child as this is somebody who is not going to stay for many more years. Yeah, so a good amount of our time goes in resolving testing done at outside labs, because now some labs I have seen even report 10 VUSs, and it is like how do you counsel families? And the other thing is, because genetic literacy is very little among people and also with doctors of other specialities, if you label them for something and a VUS, and that child is labeled like that for life, known case of dash disorder, known case of dash disorder for life, and huge list of variants, and by rule these are not actionable. Yeah, the other thing is family and social implications. Whenever we talk in genetics, we don't talk about patient child, we talk about families, because genetic testing that we do for the child has implications not only for the child but for the entire family. So sometimes we do testing for the child that has implications to the parents or to the siblings or to the cousins. And parental guilt, many times there is one component of this, is am I responsible for whatever happened to my child? Cultural stigma around genetic disorders, and non-directive counseling. So this is ICMR guidelines on ethical guidelines for biomedical research, and they have a separate chapter on genetic testing. And the first line in that chapter is, we must be extremely cautious in offering genetic testing to a society. That is because of lot of issues: privacy, confidentiality, age appropriate consent. So a child is, let us say, 8-year-old, 9-year-old, is able to understand the implications. Are we able at least to take assent from the child? And consanguinity, publication. So madam was very conscious enough to say consent was taken before I published the photographs. So are we making sure that we are actually taking consent? Because I have seen when I was doing MBBS, we used to click photos left, right, center. My phone was full of children photographs, but without consent. Although Indian parents will not object to it, but it is an ethical thing to ask their permission, at least orally. If you have a written consent, that is better, because then you can store it in your department library as an archive. But it is always better that they have actually been explained what is the use of the photograph, where will it be used, where will it not be used, and where will extra consent be taken if it is going for a publication. But it is always ethical. Again, nobody will punish you, but it is always ethical to do it. And because now there are newer technologies, so ICMR says exercise caution, because now we have genome editing, now we have PGT-M. So there is prenatal testing is coming, there's another alternative with PGT-M. So lot of professional societies have already given their opinions. It is actually repeating the same thing again and again. There is no conflict, at least in this. We have seen many times when in a particular topic two societies are giving two opposite recommendations, but for ethics it is very, very clear. So always do in best interest of the child. If child is not getting benefited, please do not do it. Okay, let us that CPK in, if the child, there is nothing that changed, child is going to develop proximal muscle weakness in 2 or 3 years of time. But if it was not in the child's best interest, do not do it. Obtain assent when feasible, because children are, their mental maturity is very good now. There is no need to wait to 12 years for assent, or whenever you think the child is able to understand what are the implications, what does it mean, please take an assent. Discourage testing for adult onset disorders when there is no medical benefit. No carrier testing in children. Inclusion and equity. Yeah, this is something that I was really impressed here in the first two talks, that we are not trying to, whatever can be done to prevent disability, we will do it. But whoever are already disabled, our aim is not to reduce it, but to include them in the society. Remember, all of us are 46 chromosomes, all of us, but some are tall, some are short, some are dark, some are fair, but we are all still called normal humans because there is a variability. So just consider them as a part of variations, and the most important crux is to involve all of them together. And counseling and support, nothing can be emphasized more than pre-test counseling and post-test counseling. If a genetic test can be ordered by just calling a person, he comes and takes the sample, why involve a genetic counselor? Because remember, genetic test is not a hemoglobin test, because hemoglobin test will give you a number and that number is same anywhere, but genetic test is not so. You are really mistaken if you think genetic test is another big test which is costing little more than other tests. Please don't make that mistake. And then special concerns with, just 2 more minutes, sir. Yeah, X-linked intellectual disability. This is some stigmatizing issue. When parents come for counseling and we say child has this disorder, but it is inherited from the then we have lot of issues, because now a father asks, can I marry different woman? No, so, and sometimes we try to hide it, saying, see, genetics is from both of you, you gave 50%, you gave 50%, although we try to hide it, and they say, no, her side of family, I see there are a lot of males with ID, I think it's from her side. Now if there is they are asking you directed question, you can't bluff to them. And lot of, now this is DTC GT is another thing, direct to consumer testing. You have this percent risk of developing obesity, you have this percent risk of that, something. Yeah, again, pre and post test counseling, please make sure, if especially if you have a genetic counselor and genetic testing facilities available, please do not undermine this. Let me see when the results come. The easiest part of genetic test is sending it. Problems start after it comes, because we have seen especially obstetricians and other specialties, let us send and see. Once let it come back, then we will see what to do with it. Okay, please involve somebody who can talk to them, ensures understanding. Yeah, so take home messages, child is in the center, so everything is around the child, because parents concerns are the same, our concern is the same. So all of us are working towards how to include this child, so make sure it actually focuses on the child. And autonomy and confidentiality and some policies, so that we can all follow it. And yeah, thank you. So as I said, all of us are different, but we are part of the garden, so we should appreciate it. Thank you very much.
Thank you, Dr. Vivekananda, for that excellent talk.